Okay, welcome to the Spine Conference. As usual, if I say something wrong, just tell me what I said was wrong. Please interrupt me. Just tell me to speed up, slow down, whatever you guys want. So I like to show illustrative cases. Hold on. So this is the case, a 73-year-old woman whose chief complaint was neck pain and upper extremity pain, right, gray, and the left. She presented in 2015, and she was referred by her next door neighbor who said that I was a nice spine doctor and maybe I could help her. She had pain in her occiput to her neck, radiated to her trapezial area, her lateral arm, not past her elbow. She had numbness and diffusely in her hands in a glove distribution. Right equals left, index finger was the worst. She had ataxia, and that was her main problem. She was falling. She has fallen 4 times in the last month. She had difficulty opening things with her hands, like in the kitchen, jars. She had difficulty taking money out of her wallet. She was slow with buttons. She had a spinal consultation who recommended no surgery. They said it's not a surgical problem. She's had multiple previous spinal surgeries, a thoracic fusion in 71 at Children's Hospital. She had a C4, C7 ACDF in 2001, an L2 to L5 posterior spinal fusion in 2010, which was revised 2 years later up to 12 for adjacent segment generation. And she has arthritis, bilateral knee replacements, right hip RF, blood clot, gastric ulcer. She is a cigarette smoker, half pack per day. She drinks 2 glasses of wine at night. She has a big family. And on exam, she's cachectic. I mean, she's 4 feet 11 inches. She's small, and she's less than 100 pounds. She has no neck extension, minimal flexion, minimal rotation, and just diffuse weakness in her extremities. But it's difficult to say how much weakness because she's a weak person, but no deficits, put it that way. So any questions so far? Presentation? Okay. So she comes in, everybody comes in with x-rays. I just showed you this is what's in her lumbar spine. I didn't do this. This is from another surgeon. And her neck. So these are flexion extension views. And what are your thoughts here, Dr. Samir?
Yeah, the lateral radiographs extension on the left, flexion on the right, showing the history of ACDF as you mentioned. The spinal laminar line is anatomic, so I don't see any obvious spondylolisthesis excuses on the examination. But with flexion, it appears that the atlantodental interval may be significantly open between extension and flexion. And also, the top of C2 is there's no clear normal anatomic finding here. I mean, I cannot see the top of the dents that well. So you can see that C2 is in an abnormal location.
Yeah, so here's the bottom of C2. Where'd the top go?
Possibly that it's through the foramen magnum, above the foramen magnum. It's hard to tell on this X-ray, but you're also going to be dealing with severe erosion of the dents as well.
It's difficult to say, really. Okay, so here's the CT.
So the CT basically shows that you have pretty severe erosive changes of the dents. Really don't have a normal yet. And just looking at the CT, I would imagine the MRI would show possibly a large planus, a lot of inflammation there.
You're going to get your MRI in a second. How about the Atlas?
It's also pretty much severely eroded, and there is, it's. I mean, we really don't see any normal anatomic alignment there. Mm-hmm. So, and also the posterior arch of C1 is anteriorly positioned. Mm-hmm. You can also say that the C1, C2 distance, interspinous distance is widened a little bit.
Right here. Mm-hmm. Mm-hmm.
So your main concern and you saw that for the X-ray is instability for this patient of reflection and extension.
Okay. Does anybody want to add any? And it looks like the C4 to, I don't know how much this, but C4, C7 looks pretty solid. So it's a good fusion.
What's your differential heat? So we would worry about with that level of degeneration. We would worry about Axial instability.
What's your differential diagnosis? What are you worried about? What's your differential diagnosis? What are the list of things you worry about?
Diagnoses. Just give some diagnoses. Were you here for? So hold on. Let me just add. This is a 73-year-old woman with 4 falls in the last month, difficulty opening jars, taking money out of her wallet. She falls, she has numbness in her hands and pain in her neck and trapezial area. So that's her history. She has severe arthritis. I'll help you.
So this sounds like a cervical myelopathy type picture. Navigating cervix is having problems.
What's the differential diagnosis? What are the list of things that you'd be worried about? Diagnoses. What do you think, Dave? Help them out. You see that on a CT scan.
Rheumatoid arthritis, infection, unlikely tumor based on the CT scan, but anything destructive is possible. Tumor, myeloma, lytic lesion of some kind.
Okay.
Probably my leading one would be rheumatoid though.
Osteoarthritic change, unlikely. Gorham's, possible. Gout, pseudo-gout.
Yeah, gout and pseudo-gout for sure, but pretty rare for forms.
All kinds of erosive pathology we can happen to C1, C2.
What is Gorham's?
This is hearing bone disease.
That's right. I remember that from medical school. Okay. So MRI.
So the MRI sagittal T2 sequence shows basically a lot of the soft tissue components that you're not able to see on CT or X-ray, where you have a large panus on MRI. It's heterogeneous in signal. The panus itself is low T2 signal, all the dark areas. And then you can actually see where the dens is eroded. There's a little bit of, tiny little bit of bone left. And that's all looks like to me fluid or edema. So between the two sequences, I'm not sure if the patient changed position or not. It's very similar. I don't think an MRI.
It's just a cut, different cut. I just put 2 cuts. Yeah.
But there's obviously, so you can tell where the clivus is, right? I can't point to it, but right there where the basion, the opiscion is, where the basion, and then the opiscion on the occiput right there. So there's no real invagination into the foramen magnum, but you would be concerned about the central canal stenosis with possible compression of the cord when this patient is actually moving about. But as of just looking at this cervical spinal cord, I don't see any swelling or edema. But you want to look at other sequences as well, like stir sequence.
Does that help you at all?
It's a lot of areas in the artifact on the right, but
yeah, the axial cuts were indeterminate because she was moving. It was hard to get a picture.
I mean, the sagittal T1 gives you a bit more definition of where bone is, where cortex is. So you see a lot of the erosive changes, and there's almost like a pencil tip to the dens. And all that intermediate signal is your panus, basically. All of that? All of the, yeah. Wow. And so, looking at the X-rays, I didn't see much calcifications. So when you see calcification on X-ray in a finding like this, you would think about pseudogout like CPPD, where you have crystal deposits. But in this case, you would want to look at her other, for example, get X-rays of her hand if she does not have a rheumatoid arthritis diagnosis, which would help you defer the.
How do you differentiate a panus from a tumor? How do you know that's panus?
Well, you have to look at the T1 and T2 signal, and usually it's dark on both. So, and if you give contrast, in this case, you can get some enhancement, but you want to look at the bone as well. To me, it's not always going to be clear, right? You have to look at the rest of the spine, and if you see abnormal signals on T1, low T1 signal, and then you see enhancement, then you would decide with this could be a metastatic lesion that is already
So here you're saying that's low on T2?
Yes, all the dark areas. And there's some fluid signal right on top of the dents, but all of the dark signal, all that is good.
Okay.
What is the arrow pointing to?
I put that there just to see. So the posterior elements of C1, C2, they're almost kissing, and here look how wide they are. And then again, C1, C2, slightly distracted on the CT where she's sitting in there, and then the MRI, C1, C2. But just to get an idea of when this person, when you ask her if she would like 2 lumps of sugar and she says yes, where is she moving? She's moving at her brainstem. So this thing is going back and forth every time she moves her neck. And it is able to move because the flexion extension views showed that it moves, but clinically she won't move it. She doesn't want to move it because it's causing her serious problems. I just thought it was interesting. So she guards herself, which is a common thing that people do. So I also, what do you think of this, Samir? I found this interesting. Whenever I can find an old picture of somebody and compare it to the new picture.
Well, I mean, honestly, in 2015, the severe progression of erosive changes of the dents. Although in 2012, we did have evidence of almost like the smaller bite marks or small erosion, and it's just a rapid progression of disease. And also the anterior arch of C1 is completely eroded now in 2015 compared to 2012.
And in 2012, it was really high. See how C1 is very high on the dens? So it was subluxating. I thought this was interesting. It shows you like the pattern of the disease.
It also shows there is significant vascular examination. C1 is almost a trillion array. It's in the cranial magnum. 2015, where it wasn't in 2012, so she clearly has basilar vagination as well.
Okay, so I put together a problem list. 73 years old, occipital cervical instability, too much motion there. Myelopathy, she's falling. Clinically, she's falling. Upper lower dysfunction. Her cephalomedullary angle, I measured it, 126 degrees. She's C4, C7, ACDF. She's fused below. She's a smoker. She's cachectic. Her dens is eroded. She has rheumatoid osteoporotic bone, and she has severe pain. So this is my problem list. So no, she's not very compliant with anything.
Not to jump too far ahead, but is that something you initiate now before you do anything else? You wait till after you, just because of the risk of. Okay.
I would.
Okay, so Megan, take it away.
Okay, so I'm going to talk about rheumatoid arthritis, just a little history. So the epidemiology, 1% of adults with actually have rheumatoid, but 10% of those with rheumatoid will develop cervical spine manifestations. It's more common in women than men. Rheumatoid arthritis affects predominantly the cervical spine. In comparison, ankylosing spondylitis, which is another inflammatory arthropathy, affects mostly the SI joints. The manifestations of rheumatoid arthritis can be atlantoaxial subluxation, which is the most common, subaxial subluxation, as well as you can have cranial settling, which is also called basilar invagination. So anywhere between 25 and 88% prevalence of cervical spine involvement in rheumatoid arthritis patients, and the lumbar spine is rarely involved. So we're going to just go through the 3 different manifestations of the cervical spine presentation. So atlantoaxial instability, which is between C1 and C2, is the most common. It can be either anterior or posterior rotary subluxations. Anterior is most common, and that's when C1 goes anterior to C2. In that, you get destruction of the transverse, apical, and alar ligaments, which is really the most common. You can also get traumatic dens fracture that may cause that. You can get dens erosion. And often with the rheumatoid arthritis, you get a pannus that's actually around the synovial joint between the dens and the anterior arch of C1. That can also result in additional compromise to the space available for cord, which is basically the canal. So this is just an image of the histology of what a pannus would look like.
So it's like a destructive process, and that erodes bone.
So going on to subaxial subluxation, this occurs about 15% of the time, so not as common as atlantoaxial. You get autoimmune destruction of the facet joints, and so it's different than arthritis because you don't get the osteophyte formation, which is actually more rigid. This is more unstable because you get just erosion, not the increase in bone formation. And that can result in spondylolisthesis, kyphosis, or this staircase deformity that you see on this picture on the right. At least this article defines subluxation as either greater than 3.5 millimeters of translation, which another article said 4, either 20% vertebral body slip, or 11 degree of angular deformity. You also can get cranial migration, again called basilar invagination is another name for it, and that's when you get erosion of the occipital C1 or C1, C2 joints, such that the odontoid will actually go into the foramen magnum, and that can cause brainstem compression as well as death. It occurs when there is a high degree of destruction of the occiput and the atlantal condyles, the atlantoaxial facets, or either a C1 lateral mass destruction.
The head cell.
Just the same thing, the head settles, and so that's because it's settling, the dens will go into that brainstem region, into the foramen, and that's what can cause compression of the brainstem and cause death.
So that's why we measured her angle. See her cephalomedullary angle? It's right at the level of the brainstem. So the
cephalomedullary angle, if you can go back to that, that's an angle between the posterior aspect of the odontoid and the medulla. And a normal angle is actually 135 to 175. And so if it's less than 135, then you're worried about for migration into the foramen. So what do you have there, 126? Mm-hmm. So that's less than the normal, so then we'd be concerned for that.
But not so much the thing going into the frame, but the deformity of the brainstem.
Correct, yeah.
Why did he die?
I thought you get compression of your brainstem, which is responsible for your autonomic breathing.
The respiratory.
Respiratory, yeah.
It's not like they go paralyzing that.
Yeah.
They stop breathing out and go away.
What's the name of that? What's the name of the condition?
Respiratory, I don't know.
No? Ondine's curse.
What?
Ondine's curse. Look it up.
How do you spell that?
Ondine, O-N-D-I-N-E, I guess, curse.
O-N-D-Y-N-E.
Ondine's curse. Ondine was some Greek.
Was that your professor? That was your professor in...
Killed people or something like that. That's the way it gets studied.
That wasn't Greek. It wasn't Greek. It was Armenian, probably. All right.
You're counseling these patients also about, their increased risk of being in a car crash and things like that. Right? They could have a high cervical injury just from a whiplash injury.
Increased risk of paralysis.
Yeah.
Yeah, the risk is still quite low, but.
So going on to just the clinical presentation. So 33 to 50% of all rheumatoid patients will have cervical instability that are actually asymptomatic. So from a primary care standpoint, or even if someone's being followed in the orthopedic, you really should making sure that they don't have any cervical involvement, since they may not have symptoms at the time of presentation. But if they do have symptoms, it can range from neck pain, decreased range of motion, altered mental status. You could have myelopathy, which can present as muscle weakness, atrophy, numbness, tingling, paresthesias, bowel bladder incontinence, hyperreflexia, gait instability. You can also get occipital headaches, and that's actually secondary to impingement of the greater or lesser occipital nerves, which is the medial division of the dorsal rami of C2 and C3 nerves. If you have C2 nerve claudication, that actually may cause pain in the face, the ear, and the mastoids as well. And when you have C1, C2 instability, that can also present as vertigo, syncope, nystagmus, dysarthria, swelling difficulties, or facial numbness and tingling. So laboratory findings, so only 80% of patients will have a rheumatoid factor present, and that's actually really low specificity. It's seen in other diseases. You can look for an anti-nuclear antibody that 30% of patients will have. You always want to get ASR-CRP. You can get serum globulin levels. Interesting, CRP is actually shown to predict the risk of joint deterioration. You can also get anti-CCP and anti-MCV, and that actually has a higher sensitivity and specificity than the rheumatoid factor, and that's both predictive and prognostic of rheumatoid arthritis. They noted that the anti-MCV is specifically or especially good for patients who have a positive rheumatoid factor and then a positive anti-CCP too. Patients who have a seronegative for rheumatoid factor but a positive CCPP actually have an increased radiographic progression and poor functional outcomes than other patients with rheumatoid. So going into just standard radiographic imaging that you want to get a standard AP or PA, lateral flex neck extension and open mouth view. A CT may be actually better than the open mouth view. What you're going to be looking for, just for a quick high yield ones, is the atlanto-dens interval. That's between the anterior C1 arch and then the anterior aspect of the dens. In men, it's usually, if we're talking about adults, men is less than 3, women is usually less than 2.5. Here in this article, they indicate instability to be greater than 5 millimeters, and if it's greater than 10, you may have complete loss of structural integrity of the transverse apical and alar ligaments. And in the one chapter that we read, it indicated that the surgical intervention would be indicated if it's greater than 6 to 10 millimeters. But another article said that an increase in the ADI is not necessarily an absolute indication for surgical intervention at C1, C2 subluxation, since that's actually common in rheumatoid patients, but few actually develop neurological sequelae. The other important radiographic finding to know is the space available for cord, and that's the distance between the posterior aspect of the dens and then posterior C1 arch, and that's really just the diameter of your canal. And that's a more reliable indicator for neurological compromise, because if you have a smaller area for your spinal cord, then you get spinal cord compression. And that's if it's less than 13 millimeters is you're worried about spinal cord compression. And then the open mouth view looks at your odontoid erosion, and you can also look at any asymmetry of the lateral masses.
So one thing there, Megan, is remember that space available for the cord is from the posterior aspect of the pana, so wherever that is.
Okay,
right?
not necessarily the dens.
That study was really based on MRI scan, not based on X-ray.
Correct.
So this gives you ideas.
That's why it was important to look at MRI scan rather than X-ray. But although you mentioned it's an indication, it's a controversial indication, because if someone's completely asymptomatic and the only thing you're doing is operating for a space available for the cord of 13 or less, it's a little bit of a hard discussion to have with patients. So you have to take it with everything else you're evaluating.
And so just talking about the natural history, without treatment for rheumatoid arthritis, the spine can be associated with really progressive disability, resulting in a C1, C2 dislocation, and really the risk for sudden death caused by brainstem compression or cord compression. And actually, one study said that the 7-year survival is really low for patients who have myelopathy secondary to C1, C2 subluxation who actually refuse surgical treatment. So non-surgical management could be physical therapy. Soft collar really is for comfort. The hard collar for known spinal instability really has shown no evidence that it reduces neurological compression or prevent further subluxation. Really, the external immobilization does not control that instability. So even if they're wearing it, you can't say that's going to protect them. A lot of the medication treatments are the DMARDs, the TNF inhibitors, biologics. An early initiation of the meds prior to the onset of any kind of cartilage damage actually can prevent or significantly diminish the extent of joint destruction, which is really important. But they have shown, interestingly, that the use of biologics did appear to prevent development of new spine lesions. But once you have a spine lesion, it doesn't prevent the progression of the existing lesion. So it's really important to get those medications before, as soon as you can. And here we can just go over the indications for rheumatoid arthritis from a cervical spine involvement. A lot of it actually is very similar to what we would think about in any spine. If you have progressive neurological deficit, if you have pain or any symptoms that is unresponsive to conservative treatment, we already kind of discussed the radiographic risk factors that may be controversial. This, if your space available cord is less than 13 or 14 millimeters, and if you have a cervical medullary angle of less than 35, that may indicate that you need surgery as well. And just a brief, very brief overview of types of management that you can have. So C1, C2 instability would be performed with a C1, C2 posterior fusion. If you had the cranial invagination early, it said that you could start with a C1, C2 fusion. But if it's a little bit later in the disease, you may need a suboccipital craniotomy and a C1 laminectomy. And then if you have really persistent compression of the brainstem or narrowing of the foramen magnum, you would need a transoral dens resection. And then for subaxial instability, you could do a posterior spinal fusion with a laminectomy to allow up space for the cord.
So does anybody want to add anything at this point? It was a good review, Megan.
That's great.
Okay, I just have a couple images to show that of things that Megan described. First, who knows who Atlas was? Because Paul likes things like this. He was Greek, he wasn't Armenian. He was a titan that held up the world. Zeus punished him. He had to hold the world. So basically the Atlas holds up the world, which is the skull. And this is a nice cartoon which shows the synovium about C2, the dens. And you can imagine if that thing proliferates, it can destroy the dens. And we need that synovial joint to move. And this is the patient we're talking about. She has a odontoid erosion, which is a hallmark for rheumatoid arthritis. And this is just an image of C1, C2 instability and the atlantodens interval. And you can see if you have that, the spinal cord's compressed. And what Megan said, the space available for the cord or the posterior atlantodens interval can compress the spinal cord. She also described the basilar invagination where the C2 goes superior, the different names that it's called, and subaxial subluxation, and cephalomedullary angle. It should be straight. I mean, sort of a normal, and you can see how that's compressed. This is from Panis, though. So just a couple. How do you diagnose, Paul? How do you diagnose myelopathy in the office? Do you have any tricks?
Yeah, there's a lot of tricks to do. Reflexes, gait, and walking, or I come walking tightrope. But kind of, look at their hand function, rapid supination, pronation, opening, closing of the hands, Hoffman sign, basic tests.
Mm-hmm. And just the other thing is I always watch everybody walk. It's an important thing. They don't scissor, and if they scissor and spastic, then it's obvious, but most people are not like that, not that bad. And the other thing is they have a wide base gait, like a child with cerebral palsy, slow cadence, short strides, dysfunction of the hands, buttons, dropping objects. I'll just go over this quickly, just the lateral view. The other thing is Clark Station is just a quick view. C1 should be at the top third of the dens. Usually you can't see anything in these, everything's destroyed. And Megan went over the test. This was in my recertification exam. If the ADI is greater than 10, it means the transverse ligament and the apical alar ligaments are gone. I just took the test last week. Romberg's test is another test of closing your eyes to check for proprioception. Has anybody here tried to do Romberg's test with one foot lifted? It's not easy. If you guys try it. So just a couple of topics about the anatomy. The C2 is a very unusual bone. It swivels. Posteriorly, there's a very thick atlanto-occipital membrane that goes from the occiput to C1. So again, C1, C2 has to swivel, and here is the most important, the cruciform ligament, and part of that is a transverse ligament, and if you cut that away, you can see the apical ligament from C2 to the top, and then the alar ligaments. These are all test questions. These are all the different lines. I mean, I basically just look at the foramen magnum and look at C1, C2. It's like a quick on the CAT scan or the MRI. And I had this guy come through my office with pannus, and I was wondering, what does C1, C2 look like? And so I looked into the emergency room of who came through last night, and I got all the CAT scans, and it's just interesting all the different type of arthritis that occiput C1, C2 can manifest as. We discussed the pannus, the proliferation, which compressed the spinal cord. It's a joint. And this is another case. I'm going to go quickly. He was 88, and he had a massive pannus. And you can see how it, over the course of 5 years, here it was 5 years prior, and it just grew. It's giving him myelopathic symptoms, stenosis. And he had a rotatory component. You can see that compared to that. And he had a posterior decompression. Now, these cases, I think, have benefited from the instrumentation. And this is just one plate for the occiput. But one thing to remember is the occiput has a keel, like a boat. So the occiput, you can see the keel right here that can accept instrumentation. And the instrumentation has to be below the external occipital protuberance or the inion that you can feel in the back of your head. And the screws are flat. And there's a sinus up here, so you don't want any instrumentation above the superior nuchal line or the inion that you can feel. And this is the transverse sinus posteriorly. So the instrumentation should be inferior to that, towards the foramen magnum. There's different screws that you can use at C2, pars screw, or the pedicle screw, or the lamina screw. And these are the different lateral mass techniques that you can try to use. And I usually use tongs and the head up a little bit for venous drainage and just laminectomy. And I won't show this video unless you want to see it. This is well, I'll show you. Everyone know what the Lobster-Tail Technique is?
I say that especially to Cami.
Let's see if I can do this.
Okay, thanks everybody for coming.
So you make a trough.
Just so you know what my day was like, I had sort of a stressful day yesterday, the surgeries. So I'm
make a trough on either side
of the lamina. So I'm just going thin,
at the
thin,
junction
air sucking from me. I keep going thin, thin,
lamina and the lateral mass,
and feel when I'm through.
And then
above and below,
you disconnect basically the lamina
that keeps you safe from the dura, so you're not drilling right on the dura, because you don't want to do that, because then you get a spinal fluid leak. Although the AMA bit is okay. Here's the Lobster-Tail. So we lift, so it's
trough up and down, say 3 or 4 levels or so.
But it's still attached to the
ligament
inflatum, and this is the spinal cord here.
Lift it off.
And now it's peeling off like a Lobster-Tail. See that?
Away the attachments.
We're pulling it off indirectly.
Spinal cord.
And that's the safest way to do it. But there's always
these
attachments.
She had severe attachments because she was compressed for so long, and she had a lot of motion. I think that's why she had so much
it develops scarring.
It just gives you an idea. This is like a Lobster-Tail technique. It just looks like a
Lobster-Tail. Dura. So now we're pulling off the lamina off the spinal cord.
It's just one way to decompress. I feel it's safer.
Off these epidural, relating it violently, and also we don't want
any role for preoperative traction.
I don't think so, but I mean kids maybe that are more flexible. But I'd be worried for this woman because she moves a lot and she moves at her brainstem. So So let's go to the treatment. So what are the treatments? What do you think? What do you think, Justin, for her? This is her problem list again. How would you manage it?
Yeah, I mean, because the guidance isn't really overtly compressing the cord there, it's more of an alignment instability issue. I don't think you need to go transorally and decompress it. And because she's previously fused, you really don't have any penalty for extending your fusion down below. So I think she buys a posterior decompression, C1, C2, C3, with occiput to wherever you want to go, 5, 6, 7. She's fused previously. In the cases like this that I have done where they have a kinked brainstem like that, I will admit them before and put them in just a little bit of traction. I think it realigns their spine, and they still have muscle and ligament attachments there, so it also gets them a little bit more comfortable because they're hurting so much often, those severe occipital headaches. So I found that's helpful, and then in surgery, if you keep in traction for a day or two in surgery, they're so much more well aligned, just the ligament taxis kind of pulls them into alignment. I don't know that in this case, she seems so sloppy, maybe you just get her in the OR and you put her in the traction. And you can watch it and you have monitoring going, it might be a little bit safer. But I have done that, and it's been helpful. We used to do it during fellowship a lot too.
How about Paul? What were your thoughts about this case?
I agree. I think the advantage of trying pre-op traction is to see how she responds to traction while she's awake, as opposed to if you put her in traction awake and she's gets neurologic dysfunction, then you're going to be a little more concerned about intraoperatively positioning her. So I think there's an advantage to trying to do someone like this where you really want to try to distract her out a little bit to do some pre-op traction. But I haven't done. We really don't see this extent for arthritis.
I think it's less because they're being treated with biological.
Yeah, I can't. I mean, when I first started practice, we saw quite a bit of this, but it's really rare now that we see people to this extent because I think of the biologics and stuff that people are being treated.
They're treated early, yeah. Okay, so just a couple things is I just want to add is pre-op. I get a. What do you do about, where do you put your instrumentation? Do you have any, I'll tell you what I do, but what do you plan, like pre-op planning, what do you do?
So I use an occipital plate du jour, and then I would, in her, I would look at the CT scan to get the anatomy of C2. Like you mentioned, there's sometimes where there's rotation, and you have to be really careful about apparent anatomy of C2. But I would generally either use a pars or pedicle screw at C2. And then lateral mass fixation distal to that. And it generally lines up pretty well, by the way.
Yeah, so I get the MRI, the CAT scan, and I get a model, because I'm not as smart as you, and I look at all three, and I plan my screws in my head, and then see what their C2 looks like, because they're so variable. I mean, everyone's C2 and C1 are very variable in the artery. But the other thing I want to make a point is I look at the lateral, and I think to myself, where will the spinal cord go if I take away what lamina? So in other words, if I take away this, what's going to look like? If I take away this, what's going to look like? If I take away this, and I kind of plan my decompression in that manner. So in this patient, she had an occiput to C7 fusion, and then I did a laminectomy down to C6. And the reason why I did that is I thought I had to do that so that it can drape and be straight as possible. The problem is it's going to drape backwards and maybe cause a problem too, like a deltoid palsy. But I thought it'd be safer if I went down to C6 laminectomy wise. And just in case, just details, she lost 1.2 liters, operative time was 5 hours. And C1, C2, the ligamentum flavum was very adherent to the dura, like with a lot of attachments, but it was peeled off without a problem. And you can see the post-op MRI. C6, the lamina of C6 was removed down to here, but I think that helped so that her spinal cord could drape backwards and kind of look normal. You can see how normal this looks. Yeah, but just from I get position, and the traction. And just a post-op CT. I get everyone in these cases. I get a post-op CT because you can't really see anything intra-op. And what do you guys think about this screw? Is it a problem or? So 2 months later, she did. I mean, so clinically, she did absolutely fantastic. She did great. She was so happy. 2 months, 4 months, totally happy.
Did you use BMP?
No, but we're going to talk about that in a second. I used iliac crest. So what's the worst thing about, what's the worst factor for good results in every study? What's the worst predictive factor for good results? Long-term follow-up, right? So whenever you have long-term follow-up, people aren't so good. So she comes back 2 years later, and she says she was taking out the trash, and she felt a pop in her neck, and now she has pain again. So what happened? What's that? There was a DePuy instrumentation is faulty, and it broke. And why did it break? Huh? Yeah, non-union, smoker. And in the interim, she had an above-knee amputation, so you can't really assess gait anymore. She's wheelchair-bound. So now what? 2 years out? Now what do we do? Huh? CT scan was not so helpful, and the MRI was not so helpful. No spinal cord compression. How would you guys manage this? Anybody? Ignore it?
Wants to be revived, repeat it, and do the kitchen sink on it.
Yeah, so I did what Justin said. This time I used BMP. I used the medium BMP and just took everything out, replaced everything so the DePuy rep can make more money, and just revised everything. And immediate post-op, she felt better. She felt stable, and you can sort of see the Mastergraph BMP here. And then 6 months later, she was absolutely fine. And I tried to call her for this conference to get like a 4-year post-op, but her phone wasn't working. So.
What did the break on the actual site? Was it the tension of the rod, or was it
the rod? The rod broke. The rod broke where it attaches to the plate.
So the rod that broke wasn't the plate itself.
Mm-hmm. So this.
These are really hard cases to fuse, especially when you have to do a lamiate at C2 and C1, because you take away all that bone surface area.
Right there.
C1 and C2 fusions, if you get maybe arch impact, is great. You put a piece of bone and a crest in between. But when you have to, you're obliged to take that out. It's a high risk. There's no great surface area. You're hoping that the occiput somehow finds a way to stick and bridge to C2 somewhere.
Yeah, I just drilled the occiput. C1's gone. And hoping that the bone could bridge from the occiput to C2 lateral masses, but it failed. So, what? Any questions or comments?
I had a question about the fixation. Dr. Torwan brought up using arch fixation in C2 and lateral mass fixation. Call for that. What's the reason for that?
Well, C2, you get a really long screw, so you get the best fixation at C2. This person had a fusion at C4 down, so to leave 3 out of the equation or down, you want to extend down to the previous fusion level. So since they had the fusion down to 6 or 7, you're just buying extra fixation with no loss of range of motion, no cost to the patient other than some exposure. So I can't see a good reason. Like Spiro said, he decided to decompress all the way down there anyway. So you've already exposed, you've done your decompressions. It's kind of almost a no-brainer that this instrument done that well.
Then the other thing I didn't talk about was C71, because C71 is open, and that's the only open part of her whole spine.
Yeah.
So would you guys go down to T2? I mean, I decided not to, but.
Not this time.
Huh?
Typically not, we should live long enough.
Yeah.
That could be a problem.
I didn't want the case to go long, so.
But it's way easier to do thoracic to attach to cervical than occipital cervical thoracic all at once. The rod comes through, that's really tough. So a revision, if she failed at C17-1, is way easier just to kind of bridge that level. I would have done exactly what you did. What's the risk? You think it's a higher risk for blood loss in patients with rheumatoid undergoing posterior spinal fusion versus non-rheumatoids? Maybe the most recent yellow journal. Yeah, higher risk for blood loss in rheumatoids. So like 1.2 liters, I think that's pretty good for surgery that's that extensive. for the smokers, BMP is off-label use, as you know, for anything other than an ALIF inside an LT cage, titanium LT cage. We use it all the time, but in a smoker, rheumatoid, poor bone quality, I think it's certainly justified, maybe even at the outset, with the iliac crest. They're just the most stringent healing environment. Posterior cervical is tough to get to deal with anybody. Add the rest of it to it. So.
Some people reconstruct. They take ilium and they cuts of ilium.
On leg graft.
Yeah.
Mm-hmm.
Would you have done that?
Maybe in hindsight. I don't know. I think I would have done what you did. I would use the iliac crest. Maybe I would have used BMP at the outset. I'm just trying to think of the cases I've done in the past where sometimes you BMP, but I don't know.
I'm surprised too that the rod gave out and not her bone. Because she's a cachectic woman. It's kind of interesting.
Yeah, certainly good points.
Just the final thing here, Undine's curse. According to French and German mythology, Nymph Undine discovered that her husband had committed adultery. Because he had promised his every waking breath to her, she cursed him that as long as he was awake, he could breathe, but if he ever fell asleep, he would stop breathing and die. So it's actually a medical condition marked by malfunction of the nerves that control involuntary body functions, causing breathing to require conscious effort, and therefore meaning patients will die if they fall asleep. So it's
Undine was the name of the man?
The nymph.
The nymph.
So it was a woman who cursed the man.
The nymph cursed the man.
Yes.
Because he was unfaithful. That's a good one. I knew it wasn't Greek. Greeks, we don't do that stuff. All right, thanks to everybody for coming. It's great. Thank you very much. Yeah. I didn't record it. Yeah. Oh, hey, it's nice to meet you. Yeah, I'm sorry I couldn't make it. Welcome. If you ever, if there's anything I can do to help you, just contact me. I'll give you my cell phone. What's your cell phone? 717-521-9264. And
you said you're going to be at the.
And I'll give you my email.
I'll be a good but I'll do my procedures here.
I prefer email if you don't need to speak to me right away.
Sure. Yeah, thank you.
Yeah, you're welcome. And if there's anything I can do
I'll be completely open, so
to help you.
You might sign in for.
Okay.
He doesn't do a lot of like titrating off medication.
No, you're from York. I know you're from somewhere up there for some reason.
Okay.
Yeah, for just a little bit.
That's what I was
Yeah.
Are you doing the Lobster-Tail
No.
thing?
Yes.
I mean, literally, it was only.
What tissue removal, laminectomy?
Oh, yeah.